So you want to talk about a loaded question, trying to understand the mechanisms that are driving individuals who have obstructive sleep apnea to experience the dysfunction that occurs with sleep disorder breathing. Well, we're going to have a little bit of a slippery slope because of the fact that there is still a lot of argument even of how we are defining obstructive sleep apnea because of the fact that we know that this is really quite an inadequate paradigm where we're utilizing still things like the apnea hypopnea index. We now see people utilizing things like hypoxic burden. What is the percentage of time that someone is spent in a desaturated state overnight? Now, with that stated, both of those are still failing to really look at the full neurologic picture that is occurring with sleep disorder breathing. What we know about obstructive sleep apnea is that it is not a lung problem. There is nothing wrong with your lungs. It is a brain problem. And what we're looking at is an increased susceptibility to collapsibility of your airway, failures of appropriate arousal mechanisms, or the opposite, overactive arousal mechanisms, which then are going to lead to further sleep fragmentation, further desaturations, and a vicious cycle that is then going to create an increase in your sympathetic nervous system or your fight or flight nervous system. This now is going to introduce the cascade of a neurodegenerative type of experience. It is also going to influence our neuroendocrine axis. Our cortisol is going up, our glucose is now becoming dysregulated, we're becoming pre-diabetic, diabetic, and this now is introducing a whole nother segment that is going to further confuse the clinical picture as to what might be blurring that cognitive state. Now, in the most simplest form, one could argue that the individuals who are experiencing their earliest symptoms of cognitive dysfunction are going to first experience inattention. Why is that? Because no matter what the insult is to your sleep, it is not going to do any favors to your ability to maintain wakefulness and to be able to attend. It is important to recognize that when we're talking about the learning process and cognition in general, I need to first be present, be able to attend in order for me to be able to receive any information and also to be able to bring it back to my awareness to be able to re-engage. So the most simplest form of cognitive dysfunction that we're going to see is going to be impaired attention. And now, although I very lightly say simplest, we recognize that that can wreak great havoc. Not only the sleepiness, but also the inattention can literally be life-changing and life-ending because of making neurotic decisions such as behind the wheel. Now, when we're looking at the longer-term consequences, when we're seeing individuals who are continuing to have untreated or inadequately treated obstructive sleep apnea, we now are seeing a whole constellation of neuro changes that are going to occur. You're going to change how my brain is signaling in order to maintain wakefulness and maintain sleep. Those are going to have consequences on the neurotransmitters that are necessary for being able to continue to have the right synaptic experience to be able to have appropriate cognition. You then are creating a pro-inflammatory state, which is going to increase the accumulation of things like beta amyloid. You then are also interrupting my ability to have the appropriate lymphatic system to be able to get rid of the garbage that my brain is supposed to be releasing while I'm having that beautiful slow wave sleep where I should be having that nice stable breathing and stable autonomic experience. Instead, the individual who is continuing to have sleep apnea and progressing in a severity of sleep apnea, moderate to severe, we are no longer being able to have any of those beautiful experiences and therefore are going to suffer the consequence. The same thing that we see in regards to it causing things like a heart attack, it also is causing the brain attack. And that may be occurring in a foul punch where you're experiencing a stroke, or it might be that slow accumulation over time of you losing that pizzazz, that extra pep in your step. And it's important to recognize that this isn't a rare occurrence. We expect about 30 million individuals in the United States are living with obstructive sleep apnea. However, we're failing to identify because only 7 million are currently being diagnosed. So you may be asking a question of when should we be treating obstructive sleep apnea and what are the signs and symptoms or features, perhaps from a neurocognitive perspective or from a psychiatric or mental health perspective? The reality is that many people are coming into our practices not just because of snoring. They many times are leading the conversation, giving you the answer from the opening dialogue. Doc, I'm here because I'm not able to do the same work I used to be able to do. I can't recall what I'd like. I'm really irritable or moody. Unfortunately, we many times will utilize an implicit bias to then gender stage it of you're a woman, you're complaining of these things, and likely it's just insomnia. You're going through menopause. It's probably because of the you having your hot flashes. The reality is we're missing out on the opportunity to identify and appropriately diagnose and treat individuals who are telling you the answer from the time that they open up their mouths to explain why they're there. We need to first take a moment and listen to what our patients are saying because they give us the right answer every time. It's only when we foul it up with our own interpretations of what it is that's being communicated that we lead them down the wrong path. So, what are some of the signs and symptoms that you should be looking for? So, number one, is there an individual who is describing to you that they are having one, lapses to sleep inappropriately during the daytime, inability to maintain attention, have appropriate recall, struggling with work that they used to be able to do? Some will even misterm this as something like fatigue. And then it is also important to recognize that women may have a different characterization of what their experiences are. Not feeling well rested, waking through the night, difficulty staying asleep, feeling irritable or moody, and may very well be occurring around menopause. Women are going to be experiencing that double whammy, however, where they're not only seeing a drop in their estrogens and progesterones, which are going to lead to some of that brain fog and cognitive clouding, but those same hormones are also going to increase the susceptibility and make it much more likely for them to have sleep disorder breathing. As a woman who has not yet gone through menopause, I can tell you that based on my facial structure, once I go through menopause, I can guarantee that I will have moderate to severe OSI. And that is because I'm going to have a more narrow airway that is going to be more susceptible to collapsibility, despite being close to 100 pounds. And so it is important to recognize that weight is a very, very important modifiable risk factor for obstructive sleep apnea. And when 75% of the US is overweight to obese, it is important to make sure we're prioritizing screening there. However, it is also equally important to make sure that we're not biasing or stigmatizing a person who is of a slimmer fit from potentially having a diagnosis that is quite treatable in today's day and age. So I'm sure that the burning question that you all have is whether or not, if I treat my obstructive sleep apnea, is this going to be the beautiful return of the cognition in a person who I was 5 years ago, 10 years ago, before I developed this darned sleep disorder breathing? The reality is that the evidence is still out on who it is that is going to actually have the full recovery versus the modification. What we do know is that an individual who's experiencing daytime symptoms such as sleepiness, inattention, mood instability, treating obstructive sleep apnea is going to help in rehabilitating some of those symptoms. We are going to see that there should be improvements when they are taking their whatever their treatment is. And now I say that because CPAP is not the only treatment. We see things like tirzepatide, we see PAP therapy, we see dental devices or mandibular oral mandibular devices. We're also seeing that we're having an increasing number of neurophysiologic type of treatments, including in Nyxoah, the most newly approved treatment for hypoglossal nerve stimulator, as well as things like Inspire. Now, when we're utilizing these things consistently, the same as with any type of medical disorder, we are then going to see progressive improvement and then potentially a stabilization. It is important to think about what is our pre-risk assessment. So before we had obstructive sleep apnea, what was our abilities and what was our risk stratification and profile? For an individual who's living with something like a risk susceptibility for Alzheimer's disease, when you are going to have an individual who is treated versus untreated, the untreated individual is going to have a more aggressive progression to the development of something like Alzheimer's disease, where although the treatment of obstructive sleep apnea is not going to stop it, it is going to slow the accumulation because I'm now taking away that double hit. With individuals who may have other long-standing medical conditions, it is something that we need to be thinking about of, are we going to get back to my college age type of intellect versus being able to roll it back to maybe the last 5 years, 10 years. So, with that stated, although that we can't say that there is a blanket statement that everyone is going to get the same degree of improvement, what we do know is that when you are reducing the insult to the brain by restoring the ability for someone to have more stable breathing, we are going to provide the benefit of modifying an existing risk factor for your brain's health. We're in a really exciting time when we're seeing that the number of treatments that are available for obstructive sleep apnea are only growing. We now have seen our first medication being approved for the treatment of obstructive sleep apnea with tirzepatide. When we're looking at the utilization of tirzepatide, it is really important to recognize that this is your first dual GLP-1 GIP receptor agonist. We are looking at that it has mechanisms that are affecting not only the peripheral nervous system and being able to modulate through the pancreas and being able to act on our gastric emptying. What we also know is that it has very significant centrally acting signature. And with that stated, it is very important in terms of not only what it does directly, but also indirectly with the orexin system. We know that orexin is a very, very significant neurotransmitter, especially when we're talking about the role in mood and cognition. And therefore, we may be even seeing that there's the ability to preserve some of that brain health by utilizing something like tirzepatide. We also are recognizing that there is an increasing number of medications that are becoming or going to be becoming available for the treatment of obstructive sleep apnea. We're going to see that there's a medication that will be the first oral medication that likely will be available, I'm expecting in 2026. And this is a combination of atomoxetine and oxybutynin. And that may provide some benefit, although there has been some question as to whether or not the anticholinergic effects from this medication, what will be that dance that we're going to see? This is treating individuals who are more in that mild to moderate degree. However, the ones that I'm actually really excited about as well is going to be looking at those that are going to be working on the orexin 2 pathways. And no, they're not currently being specifically studied for obstructive sleep apnea, although there has been studies in obstructive sleep apnea. We do know that these are going to be medications that are very likely going to enhance the cognitive system, and we also know that there is planned trajectory for some of these drugs already in terms of future FDA studies to be able to study these in things like neurodegenerative disease. So what we're looking at right now is really a constellation of treatments that may become more readily available that are getting to more than one thing. It's always important to remember that we're not a one size fits all, and therefore we really need to treat to the individual and to understand whatever it's going to be to allow them to be adherent and live most optimally is going to also be the thing that likely will provide the most cognitive and mood stabilizing strategies to apply. As you know, most typically I'm coming on here in order to be able to share with you the most up to date information to ensure that you're having the best communication with your patients around what is the best solution for them today. This is part of the reason as to why I was prompted to write my book, Communication in Healthcare, charting a course to better outcomes with trust, respect, and teamwork. The reason why is because I'm a part of your team, you're a part of mine. We are informing one another on what it is that we're going to do together in order to achieve better outcomes for all of those individuals who we care for. However, it also is written in the voice to not only be able to address us who are maybe delivering the care, but also us when we're on the other side of care. What are the things that we need to do to best prepare for our visits? How is it that we can be a better advocate for ourselves? So it's important to recognize that when we're trying to evolve communication in the healthcare ecosystem, we can't talk at one side or the other. This is a very important factor for all of us to be able to engage in. And if you do check out my book, I would love to hear your feedback. Let me know on what things I can communicate better next time around.